Stephen Kell, who is here in his capacity as chief button presser, but will contribute to some of the discussion, I'm sure. There's David Barras, who's here from Blackpool Teaching Hospitals Eye Clinic, and we've got Edward Ovenden, who's going to add to the discussion, and Tom Mackley from NHS England, and somebody with childcare issues somewhere. I came to somebody else's house to avoid that problem, but please don't worry about that kind of interruption. I think we're all used to it on Teams calls. So why are we here? We're here because, well, I hope you're here for the same reason that we are. Otherwise, that'd be embarrassing. We're here because we want to talk about the Easy Eye Care pathway for people with learning disabilities and autism in the Northwest, but specifically in the catchment area for Blackpool Victoria Hospital. So everybody from anywhere else is very welcome to the evening, very welcome to be part of the discussion and to contribute to any of the discussion that takes place later on. But this evening was particularly put on to engage in a discussion about the Easy Eye Care pathway in the locality of Blackpool Victoria Hospital, because we appear to have a bit of a black hole in terms of provision, and we're wanting to encourage, support and inform practices locally, and hopefully see if we can't increase the number of practices. Doesn't need to be a massive increase, but increase the number of options for people with learning disabilities in the local area. Hopefully, I haven't seen anybody leave, so hopefully that is why everybody else is here. So welcome and thanks very much. I'm going to start by me giving a bit of an overview of what the pathway is and why it's there and what it's for. I'm going to then hand over to David Barras from the hospital. He's going to hand over to Edward, and then Tom and myself and Steve and Edward and I don't know how that happened. Apologies if people were saying I was muted. People were listening to me before. Anyway, yeah, so I hope you all caught what we were doing. I must have leant on a button.
So I share my screen?
Yeah, if you could share your screen, Steve, we'll make a start. Okay, so I think we've covered that bit. So those are the learning objectives that you've signed up for. So between you, hopefully you'll be able to think about ways in which you can successfully test more people with more profound disabilities in local practices and develop strategies for doing that. And hopefully by the end of this evening, you'll have an understanding of the Easy Eye Care pathway and the Special Schools Eye Care Service. Okay, thanks, Steve. Okay, why Easy Eye Care? Why do we need a pathway? What's it for? So it's for people with learning disabilities and autistic people of all ages. So that's people with learning disabilities, people with autism and people with both. And it's specifically aimed at people of all ages. We do have a special schools programme, which we're very pleased to say has been recently endorsed and supported by the government, finally, for every child in every special school. But that leaves those children that attend mainstream school or are homeschooled or various other issues, possibly missing out. So we very specifically include people of all ages within the Easy Eye Care pathway. So practices that are part of the Easy Eye Care pathway receive additional fees, and that enables you to provide a longer sight test or split the sight test over a number of visits and appointments, keeps the patients in the community, minimises the need for referral and to secondary care and provision within secondary care. Very importantly, it links with a GP's annual health check. Every person with a learning disability gets or should get an annual health check, which includes their vision. At the moment, it can be quite perfunctory, but this gives an opportunity for a GP's annual health check to link directly into a local optician to make sure that people are getting a full comprehensive eye test. It links into the hospital eye service and trusts with a referral system in and out, because it's part of the NHS system. It enables both the practice and the individual and or their family or support workers to prepare in advance of an appointment with information and possibly with visits, so that the practice know the needs of the individual coming, whether that might be physical needs, it might be some of the equipment that might be needed, it might be as simple as something saying that the person doesn't like the strong smell of aftershave or deodorant, and that can put them off. So please make sure that you're not wearing any, or person can't read letters and numbers, so you need to make sure you've got cards or slides with pictures on. It links into and enables transition from the special school service that I just mentioned. It means that the results of the eye test can be given to the individual, but it also means that the system can capture data about that person and about numbers of people and various different conditions that they might have. It means that the person with a learning disability or autism can get ongoing support from the dispensing optician, which can be particularly important for people with particular physical disabilities, people who use a headrest in a wheelchair, for example, people with Down syndrome, people with mismatched ears or difficult behaviours. It's particularly important that the dispensing optician gets to know them, helps them to choose frames that fit and are comfortable and they're light enough, and etc. And there's specialist training for staff from WOPEC, and there's ongoing support from SeeAbility, myself in the Northwest, from SeeAbility in general, from my colleagues who have the lived experience of having a learning disability, delivering training to groups of people with learning disabilities, to promoting the pathway and ensuring that people make use of it when it's there. Okay, thanks, Steve. Okay, so we've got the special the special schools service. It's a dispensing service and eye health service. It's a full exam with dispensing on site at least annually and a written report for every child. So eventually this is going to be every child in every special school every year, which will make an enormous difference, and something that SeeAbility is very proud to have been a major part of introducing. We know from the research and the work that SeeAbility have carried out in the special schools that we have worked in, that in special schools at least half of the children have a sight problem. 1 in 10 of those have never had an NHS sight test at an optician's, and 4 in 10 have no history of eye care. And as I said before, just this June, the government announced that the NHS sight tests will be an offer to all pupils in special schools from next academic year, the year after, in 2 years' time. But that's fantastic news. And it's important that the easy eye care pathway is there so that those children, as they become young adults and adults, can transition into a service that's welcoming and understanding, and that their parents and their support workers know is going to be appropriate for them, but based in their local community. Thanks, Steve. So we're going to move over now to our colleague Rebecca, who can't join us this evening, but has recorded her contribution, which is useful because it means that it's there for us to use elsewhere on other occasions. And Steve is going to press the magic button and make Rebecca appear.
Yes, so hopefully the pictures and the sound will all work. So we'll give it a go.
So I'd like to introduce Rebecca Lunnis now.
Hi, my name's Rebecca. I work for SeeAbility and I'm an eye care champion, and I'm just going to tell you a little bit about two stories of two people who had eye problems and finally they got diagnosed. The first story is about Sally. Sally was a person who complained about her eyesight. She started rubbing her eyes. People thought it was hay fever. They took her to the doctors, and then the doctor gave her some eye drop because they thought it was hay fever. The doctor thought it was hay fever, and then eventually somebody thought, let's take her to get an eye test. And then she got an eye test, and then they found out that she had glaucoma, but the glaucoma was so advanced that it was too late to save Sally's sight. So Sally lost her sight for good.
Thanks, Rebecca.
And the second story I would like to tell you is about a boy called Nathaniel, who was a boy who was in a special needs school, and he had some quite challenging behaviours. He was deaf. He wore 2 hearing aids in both ears, and SeeAbility gave him his first eye test at the age of 5. And when they found out he could only see a few meters in front of his face with a glasses and prescription of -18, they then prescribed him glasses, and then he started wearing the glasses, and then his life took a very different path because he could see, and he's now learned sign language. He's learned to ride his bike, and he's now at college. So Nathaniel's life could have taken a different path if it wasn't for a pair of glasses. That's not an operation, it's a pair of glasses.
That's fantastic, Rebecca. Thanks very much. So seems strange saying thank you to somebody who's not here, but thanks to Rebecca for telling those stories so so fluently. Always more powerful when Rebecca or one of my other colleagues with the lived experience tells that sort of story, or indeed their own stories, because it just puts it over much better than a professional giving you professional advice or professional information. So why we're here is that we want to ensure that people are seen by competent local opticians in their local community, and that the hospital eye service is there for people who need to go to hospital. And the majority of people don't. Neither of those stories needed to involve and didn't involve a hospital eye service. Sadly, Sally lost her sight, but Nathaniel was helped by a SeeAbility optom and dispensing optician in his local school, and yet, significant sight problems. And that brings me over to introducing David Barras from Blackpool Teaching Hospitals, who can talk a little bit about what you do and the way that you do things in the hospital. David.
Thanks, Dave, and thanks to everyone for turning out this evening. Absolutely fantastic turnout. So huge thank you for being invited to talk. I'm just going to try and share my screen just so that everybody have got a little presentation just to run through. So I don't know if that's working just yet.
Yes.
Okay, we've got that. So as I say, I've popped together a little presentation based on just my own experiences at Blackpool Victoria, and my own experiences of assessing patients with learning disabilities. So I think if I. Okay, so those are the learning objectives that we had before that Dave kindly showed. But just a little bit of a background about me, who I am, and what I'm doing at the moment, and kind of why I'm here. So I qualified as an optometrist in 2009, worked for a large multiple for a number of years, and then started working within the fantastic orthoptic department at Blackpool Victoria some nearly 8 years ago now, and performing paediatric refractions as part of the assessment with the orthoptist. So the patients, young patients, would see the orthoptist for various reasons, and I would be performing the refraction to see if they required any glasses, if that was going to help their orthoptic conditions. And through doing that, we started to see, or I started to see, more and more children with Down syndrome and learning disabilities. And I knew from my studies at university about dynamic retinoscopy. It was this kind of this term and this mystical assessment technique, and the fact that these children with Down syndrome were known to sometimes wear bifocals, but I didn't know a lot about it at all. So I knew that there were some kind of gaps in my knowledge. So I contacted Maggie Woodhouse, who is probably kind of the expert in that field at Cardiff University. They have a special assessment centre there, catered purely for patients, children with learning disabilities and Down syndrome, and ended up completing the professional certificate in paediatric eye care through Cardiff University. And then I've recently just completed study in the higher certificate in paediatric eye care, which contained a lot more information about patients with learning disabilities and their implications for their eye health. So I now perform the joint orthoptic assessments still at the hospital, as well as performing a lot of solo appointments as well. So the patient will just see myself for their overall assessment. I wanted to talk about kind of why or how I've ended up being involved here, and kind of why reaching out for hopefully some better communication, and really trying to cement some links with our community colleagues for patients that have learning disabilities. Because at the moment we're getting a typical scenario would be a patient would be referred from the community optometrist, oftentimes because they've just been unable to test, they're unable to get a vision, unable to get any information about the patient. So almost by default, they've been referred to the hospital service, and they're seen by us because there is nowhere else for this patient to go, and it shouldn't be. We also operate within the orthoptic department a really successful school vision screening service, and so we screen thousands of children every year, and around 500 of them end up coming to see us in the orthoptic department. And some of them, again, are referred in because they've been unable to complete the school screening test. So they've been referred for us to do some further assessments. And oftentimes these patients come and we find either that there are no issues at all, or they have a refractive error, but otherwise everything looks okay. Following that, we then say a patient referred from the optometrist or from the school screening service, we then have a chat with the parents, talk about discharging them, that they don't really need to be under the care of the hospital. But because the patient's carers or parents are happy with the service that we provided, we've been and perhaps they were referred from the optometrist because the optometrist wasn't able to assess that patient, we keep them under our wing, and we will book an annual review to see them again, essentially for a routine eye test, just because everybody's comfortable with that situation. The issue with that, of course, is that it's potentially inappropriate if it's a routine sight test. We've got a duty of care to the whole population of the area, the Blackpool catchment area. And so if those patients are being seen for routine eye tests in the hospital when they could be seen in the community, it could be stopping someone that does need the hospital eye service an orthoptic assessment alongside myself as an optometrist, and it's stopping them from being seen. Another issue is the fact that these patients are referred to us through the school screening service, through optometrists, through GPs. We're very limited in terms of what we can do with dates and times for seeing these patients. They're usually just given a slot at a particular time of day, and they have to come because we're so short of appointments. That might be the only time that we've got available. It might not work for the patient at all, but that's what we do. Now we do what we can. So if we know a patient has got learning disabilities, if that's flagged up either through the referral, then we can mitigate that to a degree. So we can get in touch beforehand, and we can see what time of day works best, and we can try our best to see the patient at that time. Try to do it first thing in the morning, typically when the hospital is a little bit quieter. It kind of moves me on to the patients with learning disabilities coming to the hospital itself. It's not ideal environment at all. Our waiting area in the eye clinic is very busy. You generally have to park a long way away. It's an old hospital building, so it's either very hot or very cold. It's not often that it's in between somehow. And again, we do what we can though. So if we know a patient has got a learning disability, as I said before, we'll try and book them in kind of earlier in the day. We also were very fortunate to operate a clinic at Fleetwood at the outpatient centre there, which is much more akin to a community practice, and we find that the difference is huge when patients come to see us at Fleetwood, because you can park outside, it's a much quieter waiting area. You can walk straight in without having to go down long corridors, and the fact that it makes that difference means that I think that going to a community practice, it would be much better for these patients in a lot of circumstances. The next thing I wanted to do is basically I'm going to talk through my own experience. What I don't want to do to anyone is to teach anyone to suck any eggs, because there is I appreciate there are lots of people in the room here, and there are lots of people that are already doing a fantastic job and doing brilliantly at seeing patients with learning disabilities, and we've got lots of information to share, and I think we should. My goal is to have us all sharing that information with one another, what we've learned from our own experiences, and the talent that this profession has. I'm not a finished article. I've got lots of things that are left to learn, and I think that the brilliant thing about seeing patients with learning disabilities is that they're very, very good. They're very, very able. So they might have a learning disability, but they are very, very able at teaching us what we don't know. So if you think that you're on top of your game, seeing a patient with learning disabilities certainly makes you kind of question your own abilities and what you can do better. So in terms of my own experience and kind of what can I do? The kind of the title of my my presentation today is a lot of the time we concentrate on what you can't do with when seeing a patient with learning disabilities in the assessments. They can't do Snellen, you can't see the fundus, and oftentimes these are reasons for referral to the hospital. So it's kind of to turn it on its head. What can you do when you're seeing a patient with learning disabilities? If you kind of reframe the assessment itself, what positives can you take from it? And I kind of wanted to say as an optometrist, our role as an optometrist is to be vision barrier detectorists, is to try and detect any barriers to a patient's vision. So with a patient, adult patient doing a subjective sight test, it's very, very easy to detect those barriers because that patient will tell you. They'll come in for a routine sight test. My vision's a little bit more blurry. We'll do a subjective refraction. They'll tell us what they need. We'll be able to detect those barriers to their vision by the various tests that we can do, and we can then remove those barriers to their vision. We can give them a pair of glasses that enhance their vision. Testing or assessing a patient with learning disabilities is the same principle, and we're trying to detect those barriers to clear vision. We just have to do it in a little bit more of an objective way. So rather than thinking, oh, well, this patient can't do a subjective refraction, I'm not going to be able to detect any barriers to their vision, I have no idea. What can you do to detect those barriers? We can remove them for those patients as well. So by looking for the barriers to their vision, we can inform, we can advise, and we can remove some of them as well. The other big thing is that we can be very, very pivotal in disproving any what's called diagnostic overshadowing. So this is a term basically where the patient has been, or the patient's actions have almost kind of been informed, or their actions are, they're being defined, their actions are being defined by their diagnosis. So if someone can't do a particular thing, it's put down to the diagnosis of their learning disability rather than something else. So if Barry can't or never watches TV, is not interested in the TV because he has Down syndrome, is it because he has Down syndrome, or is it because he's short-sighted? And sometimes that overshadowing can come in when actually it's a different issue that's playing. We can be pivotal in that. We can do an objective assessment to look at how someone's eyes are focusing and actually disprove anything that might have been overshadowing that patient. So that's all in relation to the kind of the inclusion model of looking at things at the moment with patients with learning disabilities. So previously it was a more of a medical model where as I say, the patient was defined by their diagnosis. We're now looking at more of a social model of looking for these barriers of what can this patient do, what is this, are there any barriers that are stopping this patient from kind of fulfilling their potential, and as I say, as optometrists, we're in a position where we can look at those vision barriers and look at removing those. So going back to the assessment itself, as I say, there's lots of things that potentially we can't do, or that won't be as possible if we were carrying out a standard adult GOS sight test. But don't take that personally. So going back to, well, what can we do? What can you prove? What can you disprove? What positives can you take away from the assessment? What can you tell the patient? What can you tell that patient's parents or that patient's carers? What are your findings, and how do they relate to that patient in terms of what they can potentially do going forward? There's a really interesting article, and I think it kind of shows how new some of the how new this approach is. There's a really good article by Rachel Pilling, who's a paediatric ophthalmologist at Bradford Hospital, and she's written a paper with colleagues, basically outlining. They got together a lot of different professionals, and they outlined kind of what would be some kind of guidelines for seeing patients with learning disabilities in terms of referrals, and what can you do, what can't you do, and what would potentially instigate a referral. And there's so much advice in there. It's a really, really good read. So if you take anything away from this presentation, I think having a little look at that paper would be a really good idea. But the main guiding principle, so if a patient with learning disabilities comes to see us, these guiding principles are really, really useful. So in terms of your assessment, have there been any new findings? Has anything changed? If they have a condition, is it stable, or is it a condition that's likely to progress? And is there anything that you could do in the community which would potentially stop a referral to the hospital eye service? What things can you do as a community optometrist that would negate that referral to us in the hospital? So what can you do? The first thing one of the first things that we can do, I think Dave mentioned it before, is getting in touch beforehand. It makes a huge difference. We've found that this has been really, really big when we've been assessing patients with learning disabilities. Main reasons being that it can reduce the appointment time. So if we've got the history and symptoms beforehand, so if we've got into contact with a patient's parent, they could give us the family history, the patient's ocular history, the birth history, their general health, all before they come to the appointment, which means that for the first 10 minutes of the appointment, we're not sat talking to the parent. We can get straight on with some assessments, because we find, or I've found personally, that spending time talking to a parent before involving usually a child, it makes the child more anxious, it makes them distracted, whereas if we've got all of that information beforehand, we can get straight into the assessment. We can start playing some games straight away if it's a paediatric patient. And the other thing is we can find out what are they able to do, what might they struggle with, so that we can avoid any tests that the patient isn't likely to be able to do, because they might interpret it, or the parents or the carers might interpret it, that the patient is failing the assessment somehow. So if we know that a patient won't be able to read the letters, can they match the letters? If we know that they can't match the letters, can we rely on some objective assessments that we can measure the vision, and we can kind of hone in on what assessment might be best for that patient before we even start. The other thing that we can do is we can find out about how that patient communicates. So do they use technology in their communication? So have they got any kind of augmented devices? How do they say yes? How do they say no? So the parents can inform us of anything that the patient particularly does to communicate with them, and we can employ those same strategies. And also we find out broader information about the patient. So what do they like? What don't they like? Do they like a particular go into appointments at a particular time of day? Do they like a particular song? We often do a lot of singing in the orthoptic department because it's fun, and if we can show the patient that we're on their side and that we like the same things that they like, it kind of builds bridges, and it really helps. Another thing that SeeAbility also, just expanding on this a little bit, SeeAbility do, there's also the functional vision assessment. So this could be filled out by a parent or a carer before they come to the assessment, and it probes for kind of the patient's visual abilities, and probing particularly for any signs of what's termed cerebral visual impairment. So again, this is an extra step. This is something that we're working on at the hospital at the moment. We're not doing this wholesale at the moment, but it's something that we're trying to include in our assessment and our communications before the patient comes to see us. In terms of cerebral visual impairment, so this is essentially a visual impairment where it's not the eyes that are affected directly, it's more of a defect within the brain itself, so things like nystagmus, visual field defects, and then there's also the dorsal and ventral pathways, which are kind of further processing areas within the brain. So the dorsal pathway is what's termed the WARE pathway, where that's more in terms of object localization, so finding an object grouped in another series of objects, or finding a person in a crowd, or movement. And then there's also the ventral pathway, which is actually what an object is itself. So someone looking at an object, being able to describe what that object is, or even facial expressions as well. So there's a gentleman called George Dutton up at Glasgow, who's done a lot of work with CVI. So if you wanted to have a look at that a little bit more, there's just a paper at the bottom there. We can't, as optometrists, diagnose CVI. That has to be done through brain scans and things like that. But what we can do is, if we've got this information and we can ask the right questions, then we potentially might be able to point a patient in the right direction to get extra support, potentially a diagnosis of that as well. But most importantly, the support that they might need, depending on the issues that they're having. I popped a little bit of information about familiarisation visits. Again, we find this is really helpful. Patients coming to see us before their appointment itself. It's very difficult for us to do that at the hospital. But when patients do come for their first appointment, sometimes we find that we're not able to do anything. So we try and get them another appointment within well, as soon as we can, generally. So sometimes patients will come and we won't be able to get anything first time round, but we find on the second assessment that because it's with the same practitioner, because it's with the in the same environment, that we're just able to get much more information just by virtue of that. The other thing I popped here is, if something's not working, so if you're trying a particular assessment, if you're trying to do RET, if you're trying to do ophthalmoscopy, if you're trying to get a vision, if whatever you're trying to do isn't working, just put it to one side, and you want to be on that patient's side. So if something's particularly upsetting that patient, just move on, maybe come back to it in the same assessment, maybe just leave it for another day. And if something's not particularly worked, be it RET or ophthalmoscopy, then if you, in terms of paediatric patients, one thing that we ask is for patients or parents to try and replicate that assessment at home. So if it's retinoscopy, turning the lights down a little bit, shining some torches, holding some lenses in front. If they've got a pair of glasses, just to kind of hold the lens in front, and just to kind of mimic what we do at the hospital, just so that it is familiar. But as I say, really importantly, try not to push things, because particularly on the patient's first assessment, if it's going to upset them, then the next time that they come to see you, they might be upset just by virtue of being in that same environment. So we want to be on that patient's side. Communication is really big as well. I've just popped a little picture here of some of the tools that I use. So I made some little cards just to show the patient what we're going to do, but we sometimes put these in order. Sometimes we offer the patient the choice of which test they'd like to do. So that really helps us. And then asking or allowing the patient and the issue at hand to kind of guide the assessment. So if you know that you're going to be short on time, or if you know the patient's going to be very anxious, then we really just need to kind of think what's important to this examination rather than just going through that routine flow. Think of what's important straight away, and try and let the patient's symptoms guide the flow of the test. When communicating, we're trying to use short, clear sentences. Repetitive language is really helpful, particularly patients with autism. So if we're doing, so in my experience, when I've seen young patients with autism, when we often do case pictures, and it often involves me just shouting, "What's this?" quite a lot, and then "What's this?" and that repetitiveness kind of builds confidence in the patient. So using repetitive language, having a realization that some patients that have communication difficulties, their receptive language might be better than their expressive, so they might understand what you're saying, but they might not be able to express something back. So just being mindful of that. As I said before, looking to parents to help confirm any communication. So if they perhaps nod a particular way, or they hold their head a particular way to say yes or no, things like that. So utilizing that information that you've got from parents and carers is really, really key. Telling the patient what you're going to do before you do it is huge as well, just to reduce that anxiety, and just giving lots of time and lots of praise. So being enthusiastic. It's known that patients with Down syndrome tend to have lower expectations, and they tend to have less perseverance with some of the testing, and they may give up a little bit easier. I popped a little bit of information here about Makaton as well. Just learning a few Makaton signs that are relevant for eye tests. So learning K's pictures, Makatons, or something like that can be really, really useful. If you can speak someone else's language, then it's hugely useful. So if the patient can see that you can sign, and they can then, that it's a medium that they can communicate with you. So just knowing some of those. Popped a little bit here at the bottom, the sign for toilet. If you learn the sign for toilet, I was told by a speech and language therapist that oftentimes if a patient can speak Makaton, or they use Makaton, then sometimes you might see them signing for toilet, and it's not necessarily because they need the toilet, it's just that they want to get out of the situation. So that's a bit of a flag if you see anyone signing for toilet.
So it's Steve here from SeeAbility.
Hello.
Hello. Just to say, time is whizzing by, unfortunately.
Okay.
And so probably just fair to say that maybe you have another sort of maybe 5 minutes tops.
Yeah, I'll do just that. Thanks, Steve.
Thank you.
Okay, so I'll whiz through some bits. So we might need to change what we're using at the moment. So using a 6 meter Snellen chart perhaps isn't going to work as best as we might think. Getting closer helps. So testing at 3 meters with certain tests, using real tools to test patients, and giving a patient a choice of tests is really useful as well. So if we can, if a patient likes doing a particular test, use that test and use the same test next time to detect any changes. Lots of these tests have norms available as well. So so age match norms. So what a typical patient should be able to see. There's the K's picks. They have really good app support. So there's the Say and Match app, which can familiarize a patient with the tests, as well as their app itself for testing. I popped a little picture of a pocket frisbee here. So this is a 2 plate test, just to test some stereo vision. There's no glasses required, so it's really useful for patients that have sensory issues with wearing glasses. they can point to the correct plate, or you can use it as a preferential looking test as well. If a patient has, if it's the first test that you do and we find out that the patient has stereo acuity, then that tells us lots. It tells us that they must, by virtue of that, they should have good acuity, that they're able to fuse two images together as well. So that's lots of information all in one quick test. The other things that we can do, there's the Bradford Visual Function Box. So that's a standardized group of objects that you can use to present to the patient and see how they react, whether it's looking at the object, whether it's just a pupil constriction or something like that, to say that they've seen it. And that's a standardized group of objects of different sizes. Popped a little important note here to say that be wary of objects that make noises as well. So if you've got something that makes a noise, it might be that the patient is looking towards that object because it's noisy rather than actually that they can see it. Few quick positives that you can do. So what can you do? If a patient can fix and follow with one eye occluded, that's a good sign. If they've got good pupil reactions, that's a good sign. These are all things that you can relate back to the parents or carers. If they blink to bright lights, or if you can do a visual fields assessment using some of these objects, it's really useful as well. Popped a little note here to say about 75% of patients with hemiplegic cerebral palsy actually have a hemianopic defect. So if you can be the one to pick that up, then you can guide that patient to particular strategies in the future. I'll just whiz through this bit. So this is just looking at the patient and trying to reframe that assessment. So rather than concentrating on a visual function test, so what particular line of log mark can that patient get, or what's their refractive error, actually looking at the patient in the waiting area and seeing how they navigate the room, seeing how they interact with their parent or carer, and seeing how they interact with objects as well. So just trying to take the testing element out of it and just observing. That's something that I'm still trying to work on, just observing a patient and using that to inform where we go from there. This is the most important bit. So the biggest tool, so in terms of what can I do in the assessment, the biggest tool that I found is the retinoscope, and because it can tell us so much. There's, in terms of what can you do and what can you take away from the assessment, all of these things. So dry eyes, irregular astigmatism, keratoconus, particularly in patients with Down syndrome, if they have irregular astigmatism and it's changing, you'd be able to see a scissor reflex. Just by using your ret, you'd be able to see if they've got cataract, if they've got healthy looking red reflexes. If you just whiz it in front of one eye and it's you'd be able to see if there looks to be a strong prescription there, any astigmatism, anisometropia, is there a difference between the two eyes, accommodation, which I'll come on to, which is really, really important. And all of that just with one tool, and that's a quick objective assessment for patients with learning disabilities. If they can't communicate, we can get so much. So retinoscopy is just a massive skill, and it's something that I rely very, very heavily on. There's a little bit of information here about Mohindra. So Mohindra assessment, we might not be able to put trial frames on a patient. We might not be able to ask them to look into the distance to relax their accommodation. So if we can darken the room, ideally occlude one of the eyes, and then just perform ret, you'd be able to see. The key thing with using retinoscopy is you can actually see accommodation in action. So if the pupil is myosing, if the pupil is getting smaller and the reflex is changing, then you know that there's some accommodation going on there. And then if the pupil suddenly dilates and the reflex changes, you know that accommodation is relaxing. So it's looking at that information. But if you're seeing a patient that's accommodating when you're doing ret, that's not necessarily a bad thing. We might think it's a bad thing because we can't get a prescription, but it's not necessarily a bad thing because it tells us, again, something about that patient.
Hello, Dave. Bad news. I think we may need to hand over.
Sorry, Steve, could I whiz this last slide?
Of course.
This will be my very last slide, and then I'll come to this, just because this one's really, really crucial. So a lot of people, this mystical term of dynamic retinoscopy, and this is something that if people aren't familiar with, I'd really like you to be able to practice, because it's something that I wasn't familiar with. And then when the curtain was drawn and I could suddenly see actually how it worked and what it tells me, it's really, really big. Dynamic retinoscopy, what I tend to do is essentially a screening technique. So ideally we'd have the patient's distance correction in place, but not necessarily, because even without it, it tells us something. And so what I would then do with my ret is if the patient has astigmatism, I'd hone in, look for the lowest plus meridian of one eye, and then I would have an accommodative target, a picture, or even my phone with a cartoon on it, at about 40 centimetres. If it's 40 centimetres away, we need 2.5 diopters worth of accommodation. If I then keep the target in the same position, and I move back to arm's length from that target, so about 60 centimetres, my ret is now at 1 metre, so that requires 1 diopter of accommodation from the patient, but the target still requires 2.5 diopters. So if I'm still seeing a with movement on the same meridian, the patient is under accommodating by plus 150, which is outside the normal range. Okay, so target at about 40 centimetres, you then at arm's length with your ret, lowest plus meridian. If you're still seeing a big with movement, then you know that patient's not accommodating. Best thing to do is to practice that. So if you hold something in front of a patient that you know can accommodate, and then have a look at the reflex, ask them to look into the distance and then look close up and be at that arm's length, you can kind of get a picture of what's going on, and then try and do the same thing on someone that's presbyopic, someone that can't accommodate, and you'll see a very different thing. And that's huge. If you can get that information from a patient to see if they're accommodating. As I say, to me, it was this mystical skill that I didn't know how to do, but actually when it's kind of when it was explained to me, it's much more straightforward than I was expecting it to be. So as I say, the main point of my talk was what can you determine? Oh, sorry, actually, move on. So what can you do in your assessment? Not as much as you might like to, but with the patient's best interest, you can make all the difference. So if you can pick up on something, then that might be the next step to getting that patient some additional support.
Thanks very much, Dave. That was very full, very helpful.
Apologies.
No, that's right. But
I could go on for a long time. Yes. So I popped on as my last slide that one thing we could perhaps do in the future is maybe a peer discussion about this. Lots of different examples. If people wanted to get on board with that, if people wanted to talk about this more, then well, as you've seen, I can quite happily talk.
Thanks very much, Dave. Edward, do you want to just talk a little bit about your experience in practice?
Yes, thank you very much, and thank you everybody for taking time out of your evening. It's really encouraging to see so much support from my colleagues in community optometry, so thanks a lot. I will try and keep it brief. I mean, everybody can get to their teas. I won't go into too much detail about what I do during an exam, but more my sort of journey and experience with the pathway, but I'm happy to field any more specific questions afterwards. So my name's Edward. I work in primary care optometry 6 days a week, and I'm in a unique position. I'm split between a resident role as well as locuming all around the Northwest. And that means I see a lot of neuroatypical patients, and I see some patients within the pathway and some patients outside as part of just general GOS. So I feel very qualified to comment on which one's better, and absolutely seeing people in the pathway is massively preferable, both from my perspective as a practitioner, but also from the parents, the patients and the carers as well. We get much better feedback within the practice. The thing that attracted me to the sort of pathway in the field in general was just when I qualified. I sort of could take my mind away from the general pre-reg things and think about sort of specialisation, and I really enjoyed this area. It's hugely rewarding being able to make a positive impact in these patients' lives. By the time I sort of left my main first practice and was venturing out, this pandemic hit, COVID. Not sure if you've heard of that before. And I had plenty of time on my hands, so I did the WOPEC training, which was hugely useful, and it took an area, people with neuroatypical learning disabilities and autism, something I didn't have much confidence in at all, and it gave me the sort of mostly expansion to what I already knew. Didn't teach me much new, but just really reinforced that learning and gave me a lot of confidence to actually apply it in the real world. And then the pathway coming along is good timing, but it's not quite as time consuming or intimidating as a full sort of high certificate or a hospital placement, etc. The main benefits of the pathway, as far as I can see, is that we can identify who these patients are within the sort of clinic list. I can make sure that I've got the right equipment in place and that enough time has been set aside. It's not like a surprise I wasn't expecting. And it also means that we can get the Tell Me Optometrist About Me or the About Me and My Eyes form in. As my colleague David mentioned, it cuts out a really significant chunk of the history and symptoms portion. There might be one or two things I want to clarify, but it's much less time. That means I can spend more time doing what we want to do, clinical work with the patient, and it means the patient's not sat there in the chair getting bored, getting agitated or anxious as I'm discussing things with the parent or carer. I think that I can also corroborate David's points. We really do get better results in most cases from seeing patients in the community, just because they're a lot more relaxed and receptive. It's a more familiar environment. Eyeballs are still eyeballs, optometry is still optometry, and there's an awful lot of clinical good work we can do even outside of a hospital department. I think, of course, it's important we all recognise limits of competence, act within them, and know when to refer on when we go outside of those. But I think you'll be surprised as to just how competent we are in community practice. It's very rare there's something that we can't handle either within the scheme or without the training just in GOS. A bit of reassurance I can offer, something which concerned me was if I didn't get the prescription exact within a quarter of a diopter, if I didn't scan every part of the retina, or if I didn't know exactly which muscle was underacting, that I'd be doing a bad job. I was a bad optometrist, or I'd be punished in any way. It's not like that at all. I've never heard of anybody becoming punished. It really is a process, especially within the pathway, of just doing as best an exam you can. I've had times, especially when I started, when I was really disappointed as to what I could accomplish, and the carer or the parents come out afterwards and they've said, oh, it's the best eye exam we've ever had, or something along those lines. And it's really good reassurance that, you know, even if it's not what we'd normally expect from a routine exam, it's still a huge benefit to the patient, and it's still doing a lot of good. I think other points I wanted to make just very briefly, corroborate points about having something visually interesting to look out. I've brought one of my toys with me. It's a great little duck toy, makes a sound, has a light. You can get them without sounds as well if you don't want an auditory stimulus. I've got three. I've got a cow and I've got a dolphin as well. Oops, sorry, just refresh my screen. There we go. I've got a dolphin as well. I think it's about £10 or so from K Pictures, and it's the best £10 I've ever spent in a clinical sense. It's like magic, you know, and it doesn't apply to learning disabilities or autism either. It works with any pediatric patient. They're not paying attention, they don't want to look, they don't want to cooperate. Show them the dolphin, and just for a few seconds or so, just totally magically stunned. And it's enough time to do a cover test or a pupil response. And it's if you take anything away, it's a good tool to have. Other than that, I think the only other thing that hasn't been mentioned is just how satisfying and fun these appointments can be as well. They do offer challenge, but I think with challenge comes a bit of an opportunity to use problem-solving skills, which I think on the whole optometrists are fairly good at, but we don't always get to practice in routine work. The good example, I did almost all of an eye exam lying on the floor with a patient, only because they cooperated on the floor, but they wouldn't cooperate in the chair. It's extremely rare. Haven't had any other eye exams on the floor, but we got a lot done, and it was a lot of fun as well. And they are very satisfying as well. You know, most days I can't recall many patient episodes. It all just becomes a blur, but I think I can recall every patient I've seen on this pathway. I speak to students quite a lot, and I ask, why do you want to get into optometry? And we often say, I want to save people's visions, I want to improve people's quality of life. And you don't always see that in primary practice. It does sometimes feel just like prescribing glasses, but you really see it quite a lot on this pathway. So from a personal satisfaction point of view, I really can encourage things. It is true that some patients can be challenging. We can sometimes be times where there's little cooperation, but I would argue you get that in the neurotypical population as well. One thing I would say is I've never had a nasty patient as part of this pathway, whereas I've had plenty of nasty patients outside the pathway in a general routine eye exam. So yes, it does, it brightens up my day a lot. I think that covers everything from my perspective. I don't think I've let anything major slip by, but I think my main point is that if you're unsure, I'd be very encouraging of trying it. It's not as intimidating as it seems. It's incredibly rewarding, and importantly, unlike previous decades, the support is there through SeeAbility, WOPEC, LOC, etc. And if you're struggling in any way, we're always happy to help. If you do have any questions, please let me know afterwards, but I'll stop rambling, and thank you very much.
Well, thanks very much, Ed. I'm conscious of time, and what we would like to do is open up for a few questions. I'm hoping that I can't actually see them. I'm hoping that there's some people have put something in the chat section, any specific questions that they want to ask any of us. But just to say before we go to any questions, if there are any, that what we would like to do, following up from this evening's event, is to have an actual real meeting of actual people in probably at the hospital, but somewhere in the vicinity of Blackpool Victoria Hospital, for those practices or individuals that are interested in taking this further for their individual from an individual point of view, or from their practice or practices if they're multiples, so that we can see how best we can support people, and we can maybe answer some technical questions about how people get paid, what forms they have to fill in, which computer systems are required, and do they already have them, and those sorts of issues that people might have. But are there any? I'm looking at the time. I'm thinking any relatively quick questions that people might want to ask. You'll have to do that by putting your theoretical hand up. I'll see Tom's in first.
Well, it's not a question so much. I'm just going to fill some airspace for you while people think of their questions. I just wanted to chip in a couple of things that I think are worth pointing out. So obviously this is a pathway commissioned by Lancashire and South Cumbria ICB. Why we're doing it? We're doing it because we want to address health inequalities, and that's a big part of the NHS long-term plan. Everyone can have a sight test. It's perfectly possible, and primary care optometry is capable of doing this. So we're putting our money where our mouth is, I hope, and trying to enable that to happen. And the second thing I wanted to say was thanks so much to colleagues Conrad and David from BVH Orthoptics and Optometry. I really appreciate how engaged you've been in this project. I really appreciate the proactive approach you've brought here, and I really encourage the Blackpool colleagues in primary care to talk to you, to engage, because you are friendly and friendly specialists, and you've reached out to the primary care, and I think that's a great thing. And part of the LEHN work that I'm trying to adopt is to get the different silos within eye care, the different ophthalmology, orthoptics, optometry, primary care, all talking to each other a bit more for the benefit of patients. And in Blackpool, you've got a great opportunity here, so please reach out to them. And obviously, thanks to SeeAbility and Edward as well. You've been great to work with on this project. SeeAbility are a fantastic organisation, and again, will help you. So if you need help, reach out. There's loads of resource out there now. We can make this happen, and we can make a real big difference to some people's lives, which is what we're all about, isn't it? That's why we all went to university and trained to be healthcare professionals. So anyhow, I'll shut up now, but
thanks,
just
Tom.
wanted to say that.
Is there anybody wanting to raise anything that's not been raised in the chats? I just saw a question then pop up that seemed to be about the numbers of people that would be coming through a particular practice. One of the things we're keen to do when we talk with SeeAbility, when we talk to groups of people with learning disabilities, to families, and specifically to provider organisations, is that if there's a provider organisation in a locality that supports maybe 60 people with a learning disability, based around, to take one place as an example, around Lytham, then what we don't want is for them to take on board everything we've said and all rush off and try and make an appointment with the opticians the next week. We do now, having made that mistake once, we do now talk to them about maybe spreading that out. They're not great numbers. That's one of the reasons that this has become an issue for a relatively small group of the population. Within the population of people with learning disabilities, it's a large proportion, but we're talking about a small group of people in any locality who have got a significant health disadvantage, and that's what we're trying to address. So it's something that can be managed in terms of numbers. It wouldn't be. I mean, Ed will know more than me. It's not likely to be great numbers of people coming through in any one week, is it, Ed?
And anecdotally, I've worked with a few practices running this scheme for quite some time now, and I've never heard of a single instance of anybody becoming overwhelmed or even just having an undesirably high number of patients. It's most weeks, most practices won't have a referral through. So if you compare this to a lot of schemes like post-cataract MECs, etc., very, very accessible. I wouldn't let that be a concern in any way. And the more practices that sign up, the more the burden is spread as well.
Yeah. Thank you. Thanks. Conrad, you've got your hand up.
Yeah, thank you. It was really just to say, to echo Tom's thanks really to everybody that's put this meeting on and joined in, especially to David and Edward. Thank you so much for speaking. It will help Blackpool Hospital, but really it's about our patients. In the 25 years that I've been working in Blackpool, I've seen children grow into young adults and young adults grow into fully grown adults, and they're still coming back on a yearly basis for a refraction, because it's, as David said, it's not for our waiting area, and it's not for my good looks. It's or David's, he thought his hair looks good tonight, I have to say. It's because they're familiar with the staff and they're comfortable in that environment. But I'm sure that our local optometrist colleagues can offer that just as well, and it's much better for the patients to be seen locally than coming to the hospital. So they're my thoughts. So we are certainly open for business, and we do want to communicate with our colleagues in the community and just do the best for our patients. So please do consider joining the pathway if you are a local optometrist. Thank you.
I'd also like to say that although I said at the beginning, this was primarily aimed at those practices and individuals that are operating in the footprint of Blackpool Victoria Hospital, we don't want to discourage anybody from any other part of the Northwest, and we're here to support anybody that does want to join the pathway if it's available in your area. And if it's not, and you're still interested, because I'm conscious that there are people from other parts of the country, again, we can talk to you about how we might over the long term help to develop the pathway in other areas. There are a few areas of the country that have got the pathway. The one or two London boroughs that it's going live across the whole of South London soon, which is a big breakthrough. There's Durham, a couple of other places, but the Northwest is unique as usual in that it's the only region in the country that's got the pathway across the whole of the region. if there's no other questions that people want to ask live, I'm going to suggest that we all go and get our tea.